Today's topic is ischemic heart disease. It is divided into chronic stable angina and acute coronary syndrome. Acute coronary syndrome is further divided into unstable angina, non-ST segment elevated MI, and ST segment elevated MI. If someone comes with a complaint of chest pain, the first thing which we need to do is to take ECG and to withdraw blood for cardiac enzymes. If ECG shows ST elevation, then it is ST segment elevated MI. If it does not show any ECG change, for example, no ST segment elevation, then we can go for troponin I. If troponin I is raised, then it is non-ST segment elevated MI. If it is normal, then it is considered as unstable angina. Let's talk about cardiac enzymes. CKMB is the most useful lab test in assessing for coronary reocclusion after an MI because it typically returns to normal level within 1 to 2 days, while troponin I is more sensitive marker for cardiac injury. It takes up to 10 days to return to normal after myocardial infarction, making elevations difficult to interpret in this sort of scenario. Chronic stable angina is an imbalance between oxygen supply and demand in the myocardium. It is precipitated by three E's: exertion, emotion, and eating. The treatment of chronic stable angina is antiplatelet therapy such as aspirin. Beta blocker improves survival in patients with high blood pressure. Nitrates are given to control symptoms. AC inhibitors benefits in high risk of cardiovascular disease. Revascularization should be considered in chronic stable angina. Unstable angina is accelerated pattern of pain, increased frequency, increased duration, decreased threshold of exertion, decreased response to treatment. This is chest pain when someone has angina and tries to relieve pain with nitroglycerin and have some rest and still there is chest pain. This is considered as angina at rest. Unstable angina can be of a new onset. In some procedures such as PCI and cabbage, the person might feel chest pain later on, and this can be due to unstable angina. In the case of unstable angina and non-ST segment elevated MI, early coronary angiography and revascularization, if possible, is recommended with high-risk indicators such as recurrent angina at rest despite intensive anti-ischemic therapy. ST segment meets criteria for myocardial infarction characterized by ST segment elevation or new bundle branch block. ECG shows different patterns depending on the involvement of part of myocardium. For example, inferior wall MI, there is the involvement of right coronary artery, and we can see ST segment elevation in lead 2, 3, and AVF. Lateral myocardial infarction is the involvement of left circumflex artery where there is ST segment elevation in lead 1, AVL, V5, and V6. In the case of left anterior descending artery, there is an involvement of anterior septal, anterior, and anterior lateral wall, where in anterior septal we can see V1, V2. Elevation in anterior, we can see elevation in V3 and V4, and in anterior lateral, 1 AVL V3 to V6 leads can show ST segment elevation. Management of ST segment elevated MI is the first thing which we need to consider is PCI. The door to balloon time is considered as 90 minutes. Besides this, we need to do the oxygen therapy in order for arterial saturation. We can give nitroglycerines, but we have to be very careful if there is hypotension, right ventricular infarction, or severe aortic stenosis. Antiplatelet therapy, aspirin is given. Anticoagulation, unfractionated heparin, low molecular weight heparin can be given. Beta blocker is usually given in MI, but it is contraindicated if there is heart failure, high risk of cardiogenic shock, and bradycardia. Statin therapy should be started as soon as possible. In the long run, the management of acute coronary syndrome is via antiplatelet and anticoagulation therapy, such as aspirin and ticagrelor are antiplatelets, and warfarin, which is anticoagulation therapy, is given if there is any high risk, such as in the form of chronic atrial fibrillation. Beta blocker, such as metoprolol, can be given 2 times a day. Nitrites, use with caution in right-sided MI patient who have become preload dependent. ACE inhibitors and statin should be advised in patients with myocardial infarction.